So here's our general area. You can see it better in your PowerPoint slide. I'm in the way on this one. If y'all know how to move me around, let me know. But but yeah, so the pyloric sphincter here at the end of the stomach, he literally feeds into the duodenum. Yes, sir. There, you should know that. Look, like PD class, physical diagnosis class, pyloric sphincter, duodenum. There. Now you won't forget. Okay, awesome. All right, so it literally is a tortuous, it's rather slender tube. It's got peristalsis. You all know what peristalsis is? The movement, these smooth muscle contractions that move along food and food stuffs around. So, off chance, you guys know what disorder can affect peristalsis, like a chronic condition? It can occur as an adult. Yeah, gastroparesis. Yeah, perfect. Yeah, gastroparesis, and that's common with diabetic patients as well. Okay, so, all right. So clopropamide is a medicine we give them. It's a little powder you put in water, and it helps it move stuff along. Okay. It can also happen with post-cholecystectomy as well, because your gallbladder's gone. Now all the bile is spilling everywhere, and you got to regulate. So things get all altered and stuff. But yeah, so it's primarily responsible for peristalsis, getting food along the rest of the way. So some gentleman named Trites named a ligament after himself, so you should know it. I don't know the guy, but I think that's him calling. Like, hey. Yeah, he found out we were talking about him. So, anyways, but yeah, so what do you mean by mesentery? What were we talking about yesterday about mesentery? What's that? Yeah, the apron. Yeah. Was that the omentum?
That was
the omentum. Yeah. Mesentery had blood flow, arterial blood supply, so it feeds it oxygenation. So yeah, so that ligament here is kind of holding things together, and where the ileum meets the cecum of the large intestine, that's where it terminates. Okay, so know the difference there. So the way the mesentery is, it's like got little web-like structures that, as well as the ligament of Trites, to kind of keep it in place. Because if you got all this peristaltic movement, you all have used like a water hose before. Those cheap green ones that if you like pull them, they get a knot in the, that's kind of what can happen here if it's not secure. Okay, so be mindful of that next time you water your lawn, if you do have a lawn, or you're watching. But here it is in real life. I think that is Dr. Trites right there. That's his hand. He's showing off. Look at me. Haha. Anyways, that's where it is. All right, so duodenum. Is he the first part of the small intestine or last? The first. Why is that? I said so. All right. Anyways, sorry. Come on. So he's 25 centimeters. You know that. But it has a bit of a C shape here. Now, there's certain aspects of these curvatures where it twists and turns like a water slide at Aquatica or something like that. I'm not going to have you require that, okay? Just know that it's C-shaped. I just think that's lots of minutia there, okay? If someone has like a small bowel obstruction, they're not going to care if you know where the D1 is or all that stuff, okay? So just save their life, okay? Give them fluids, okay? So, but yeah, so to know that it's C-shaped, it's the first portion of your small intestine. So what is this large organ here that we see here? The liver? All right, good. So, all right, so I can't go back apparently when we're recording. But that was the liver. Pancreatic duct is literally right under there. That's basically what secretes your bile. The gallbladder holds bile. And when you start to eat lots of fatty foods, like if you want like a spree of months of like fatty foods and stuff like that, Bile's going to get over secreted, or it's going to stimulate more growth, and it's going to become static or stasis inside the gallbladder. It's going to lead to something called gallstones. That can create a blockage in the pancreatic region, also in the anywhere. They can travel to the pancreatic duct, can travel to the biliary duct, can travel to anywhere else. You'll learn that in GI. That book I keep telling you about, Ridiculously Simple series, they have a great drawing of how each stone where it ends up blocks certain things happen. So, but yeah, so just be mindful of that. Your jejunum is your next section. So this is like the archaic tortuous section. Okay, it's just like that garden hose. Just you're tired, you wrap it up and you fold it. You roll it up, you store it in the corner. It's all tortuous stuff. So, but yeah, so it's got little particles in there to help push food along and to increase surface area, surface tension for absorption of food. Not too much in the minutia here, but just know, look, it's mostly found in the left upper quadrant, okay? The majority of the jejunum is found in the left upper quadrant. Do y'all know that? Now you do. Okay, so if I ask you that on a test, do you guys know it or no? Now you do. Okay, awesome. All right, so ileum. So he is mostly in the, what does this stand for? RLQ, what's that? Right lower quadrant. Where's that? In the right lower quadrant? Okay. Aha. That'd be funny if I was a question. Where is the right lower quadrant located? How do you spell CPR? All right, so yeah, so this is where the small intestine comes to an end. Unfortunately, its journey is over. He's like, okay, I'm done. Now he's going to seep into the cecum, which is the first portion of your large intestine. Notice that this term Peyer's patches, you're going to see that a lot going forward, specifically in the pants. I'm actually taking my PANRE right now for the past year and a half. I've been taking it, and I think I have 2 more years of it. It's pretty easy now because you can take it at home. You have 5 minutes to answer a question. You can use resources. So no more. It's more practical for working PAs because when I took it the first time, like a long time ago, I had to go to a testing center and take time off work, and they're being difficult about it, and it's just creating more stress. But Peyer's patches is always, that term is always in there. So understand that they're a little tiny circular fold, and they're always found in the ileum portion of your small intestine. They basically are kind of like security cameras or guard dogs, basically to watch for microbes and see how much they proliferate or not. So if they get out of hand, like too much bacteria is in this area, it'll start activating your immune system to start fighting it off. Okay? That's basically what they do. They're kind of like a surveillance system. Okay, so Pyre is a security guard, and he watches over the patch. Okay, so there you go. Does that help you? Okay. If you want me to stop, I'll stop. All right. So, what is this image from? The anatomage. It's fancy.
I didn't know.
Yeah, it's okay. So we have I guess here's your jejunum. It's darkness here, but notice it's in the left upper quadrant and bottom. So yeah, so I will get familiar with your GI organs downstairs as well. Okay. How y'all went? Did y'all go there last night or no? To study? Or are you gonna go this weekend to study? Okay. Monday. Yeah. All right. I highly recommend it. Okay. Just saying. All right. So duodenum, here it is right here again. Notice its relation to the spinal column here. What is the structure right here? Kidneys. Yes. Perfect. So you have to know what specific adjacent structures are found and all that good stuff that's in your workbooks. Okay. So now we've left the ileum. We're inside the cecum now. Now it's part of the large intestine, or colon, as they call it. I mentioned yesterday it's kind of like the nodes of Ranvier for like the synaptic clefts, but in the intestine they're called haustra. Okay, so basically there are little segmentations of this structure called tenia coli. So basically they're smooth muscle bands. They're a lot much more robust than the small intestine peristalsis. They don't have any hostra. So if I ask you if the small intestine has hostra, you're going to say no. No, they're just a slender tube. But basically, it's going to make room for water, for stool, for gas. As bacteria breaks down things, CO2 gets released, and methane breaks off the CO2. All the organic chemistry is fun stuff that you all love. How many love organic chemistry? Like when we asked you in the interviews, that was like the main subject that everyone hated. It's like, I don't like organic chemistry. I'm like, oh, God, I love it. It's like, it's great. I said that right. But yeah, no, it's that's what happens. That's why it's a little larger than the small intestine. Okay, a lot more going on there. A lot of water exchange going on, and that's what keeps you balanced. Okay, too much water leads to a condition called loose stools or diarrhea. Not enough water leads to constipation and all sorts of other issues. Okay, so it's all about water balance, and basically sodium, potassium pumps, water, hydration keeps everything going. Okay, electrolyte balance have to stay in check as well. But just know that this is where most of the water exchange occurs, and know the difference between your hostra and your tenia coli. Okay, this is the anatomy of the large intestine, and this is the entirety of from beginning at the cecum to the end at the anus. So I would like for you guys to either put little arrows between here so you know where to go, or put numbers here in this structure, this image here, and white out the name so you know the order or where it goes into. But yeah, what is this section of the colon called? Hepatic flexure. What is this section called? What is this one called across here? What is this one called? What is this one called? Sigmoid. What is this called here? What is this one called? Ascending. Okay, what's all this stuff here? Mesentery. Okay. Put mesentery and omentum next to each other. Please, you guys are getting confused. Alright? Know the differences, alright? So who's this little guy right here? Appendix. He causes a bad day for a lot of people, you know. And if so, what if someone come in, where would they be complaining of pain if they have like appendix pain? Right lower quadrant. Okay, good. So what are you doing? You're gonna palpate that area, correct? You're gonna do certain tests, rebound tenderness. You're gonna do the leg lift and all that fun stuff. Smack their heel. So it's gonna just piss them off further. So just do it once. That's it. You don't have to do it like 3-4 times. Showing off to your, hey man, look what I found. Not ideal. So I want you to understand where specifically. I told you that some are found intraperitoneal, some are found retroperitoneal. So literally, that's like a big deal here. Okay, so I need you guys to like make a list, a side-by-side column or something that's going to help you understand, or kind of put 2 columns and then one that's like in the middle, like the words like transverse colon, like in between, because it's part of each one, you know, something like that. You got to understand that. That's just an example, but it's very important you know which ones are found intraperitoneal, which ones are not. Okay, it's imperative that you understand that. So your appendix is also known as vermiform appendix. So basically, it's what's another term we use for this? What's this region called? It starts with an F. When it's like gets blocked. Fecal lift. So it's called fecal lift. So a little piece of fecal matter gets trapped in here and creates a toxic environment and starts to get inflamed and angry and starts pulsating, and the person gets very, very sick, and then they start getting appendicitis. Now, notice there's not much room in the appendix. It's kind of like your forearm. There's not much space in there. Imagine if you add inflammation and toxicity and pus and all that stuff. Eventually it's going to rupture. And when that happens, that's emergency. Okay? So high fever, nausea, vomiting, malaise, right lower quadrant pain, all that stuff is going to be taken into account, okay? All right, so here's your friend, the anatomage. They have a positive circle sign here. So Carl highlighted it for you, and then here it is right here again, okay? So the ascending where's he found? Don't look. Retroperineal, awesome. You guys are awesome. Okay, sweet. You guys didn't look, right? I'm so proud of you. All right, so retroperitoneal. So understand that where it begins, okay? So there's an ileocecal valve that is located between what two parts? Your ileo and your cecal, okay? So, and it's going to terminate. So know where it begins and know where it ends. Obviously, if it's an ascending colon, it's going to terminate at the next classification, which is your close, a little bit more to the right, hepatic flexure. Okay. Cool. Yeah, you got part of it. You didn't hit the brakes too quickly. You slid forward. So yeah, just back it up. Hepatic flexure. Okay, so that's where it terminates. Notice it's going to have a larger diameter. It's going to fluctuate throughout the entirety. The diameter is going to be a little larger at the little cecal region, and it's going to narrow out, and then it'll kind of get more narrow as it's attaching here to this hepatic flexure, and then it's going to even out transversely. And then when it gets closer to the sigmoid colon, it's going to also open up a little bit more, okay? So that's for digestive purposes and to allow room for other things to occur, okay? So transverse colon, this one is intraperitoneal, okay? So that's important. So I'm not really concerned about it being the most mobile portion. It's nice to know, but I'm not going to test you on that, okay? I would test you where it's located, intraperitoneal versus retroperitoneal, okay? So also, just to confuse you, it's also called the colic flexure, but for our intestinal purposes, I'm going to use hepatic flexure, okay? And also basically spans from each flexure, hepatic flexure to your splenic flexure, okay? That's your transverse colon, all right? Ascending is right beneath that, distally, and we'll go from there, okay? You all following okay along with this? Okay. All right, so now we're going to go over here to the descending colon. Now he is retroperitoneal. So you see how everything is like going like in and out? One's intraperitoneal, one's retro, so kind of important you need to know these things, okay? Because if, let's say you're in surgery and you don't see something, we're having the rest of the transverse colon. Oh, it went retroperitoneal. You don't know that, it's not cool, okay? So you know where things are located. Adjacent structures, literally superior, inferior, medial, lateral, know where these things are. Intraperitoneal, retroperitoneal. I know there's like a mnemonic that we saw yesterday for them. If that's helpful, go ahead. You know, how many find mnemonics helpful? Yeah, for stuff like this, yeah, we got to know like a bunch of structures. Yeah, it's helpful. But sometimes when you're on rotation, you're in a surgery, and the surgeon's like, "What's that?" You're gonna panic. You're like, "Oh my gosh!" So try to understand where they are too. Okay. All right. So sigmoid colon, where's he at? Think of it like little like tree houses. You don't want to just. I'm gonna go to this one today. I'll hang out this one. So, all right. So yeah. So diverticula, those are little outpouchings that form from improper diet. I told you it's like when I was on rotation, I think I showed a bunch of strawberry seeds in between them. And then when they become inflamed, it turns into diverticulitis, which is painful and it brings people in. We give them ciproflagyl and some anti-inflammatories to calm it down. Then we stage them for surgery. Okay, we let everything calm down first, then we bring them in for surgery. Okay, it's not wise to do surgery on someone who's an active diverticulitis attack. It's toxic. Right? But here's where it's located. Go there. So yeah, I'm speaking ahead of myself. Yeah, see, here's what they look like. Diverticulosis is just having these little outpouchings here. diverticulitis, you can see it's like the tissue's gotten thicker from inflammation and scar tissue. Go from there. So obviously this can lead to bowel perforation and worse things to come. Okay. Yeah. How do you think they obtain these images? Colonoscopy. Yes, correct. So is that in red? I think so. All right. So yeah. So what's a sigmoid colon for? Yes. So it kind of just houses there, it hangs out, and it's located retroperitoneal. So that's basically a big things that I want you to know, except for the rectum. So sigmoid colon rectum do the same thing. As action concerned, the rectum found retroperitoneal. Okay. And then obviously it then leads out to the final two structures in the GI tract. Okay, so just know where those are located, know what they do. Dentate line. So there is, it's kind of like a line of demarcation. You can follow my marker here. So it's right here. So we've got your mucosal lining here at the anus. So basically, it's kind of like a border between like Florida and Georgia, basically. So here's a line. This is the state of Florida, or state of Georgia, right there. That's the line between the rectum and the anus. Okay, that's what they look for when looking for internal hemorrhoids or cyst or anything, a lesion that could be found in there, so they can identify where it's located. Okay. All right, so here's your rectum. So we're going, these muscles here, that's like a group of one of your pelvic floor muscles. You'll need to know those for like the third lecture of this block. We're gonna go real in depth into those things, okay? So just know that the rectum is remember the hyoid bone is just floating there and all the muscles attached to it. Think of the rectum's kind of like has some that are looping around it. It's kind of supporting it muscularly when they contract. So it's kind of like a big conglomeration of muscles to support the rectum, and that's going to make your pelvic floor. All right. So just understand that that's who they are, and we'll go into very much detail in the third PowerPoint. Okay. All excited about that? It's great. Awesome. All right. So notice I'm using terminology here again. So it's anterior to the sacrum. So that was stuff from the very first lecture I had. It's still there to haunt you, okay? Use terminology, be able to read it through. I'm not going to say front, I'm going to say anterior, I'm going to say posterior, I'm going to say posterolateral, anterolateral, superior medial, all that good stuff, okay? So know your stuff, all right? And what is it posterior to? So know where it's located, right? So I've demarcated between male and female anatomy as well, but understand what adjacent structures are close by, so we can, if I were to ask you a question, the rectum is superior but lateral, but anterior, not so posterior, maybe medial to what structure? I'm just kidding, I won't do that. but yeah. So vascularity. So obviously it's going to be called the rectal artery. Okay, there's three of them. There's superior, middle, and inferior. So I would understand where they come from and where they're located. All right. So that structure there, that image, what's the term? Diagram there shows you where they are. I get familiar with them. Make 3 columns. Whatever you need to do, put the picture in, white it out, test yourself, constantly read about it. We need to know what the blood supply is for this structure, okay? So the anal canal, we have sphincter, kind of like the lower esophageal sphincter. Remember we were at yesterday, and that's involving the distal esophagus and the antrum of the stomach, basically the opening part. But yeah, so these muscles if you put them together, so voluntary control is your external sphincter. So when person is ready to defecate, they can relax those muscles. Passive continence is just passively there to keep you from, using the restroom anywhere you go. But understand what is under passive and what is under voluntary control. Get familiar with these diagrams as well. So here's another diagram, a model with all the structures of the large intestine. And here's your anatomage as well. Okay. Are you guys getting the hang of anatomage? Some of you? Okay, good. Did those videos help? I just want to know because did it help? Okay. Just checking. All right. So clinical significance. All these horrible things can happen in this area. Okay. They're I did a colorectal rotation. So one thing I got to do was they have this little contraption, looks like a pistol, and it's got a rubber band on it. And they had me put rubber bands around the stalks of all the hemorrhoids. And that would strangulate them, and it would eventually declare some would fall off. So, yeah. Here's a PA student. I'm like, and they're actually like when I was out of on disability, there was a part-time job for a PA just to do that 3 days a week. And it was like from 8 to 12. It wasn't paying that much, but at least it was something. But I thought about it for a second. I said, no, I'm not going back to that. It's traumatizing. But yeah, that's how they handle them in the office. If they're really bad, they just put a little rubber band on and just strangulate them and they fall off. So yeah. But anal fissures are very painful. Those can get real bad and infected. We've had to wash out a few when I was a student. Fecal incontinence can occur from like a neurological issue like cauda equina or something like that. Toxic megacolon, this is what it looks like right here. So when you say toxic megacolon, it's this guy right here. You see that? They call it megacolon because it's mega size. So this is real bad. That's always on your boards. So there's so this is more like pathophys. What do you guys think? Yeah. So don't worry about this, okay? You can learn that in GI class at some point in your career here. Forget what semester it's in. All right. So I want you guys to know what the innervation is, okay? And look, it's our friend, the vagus nerve. He's really busy. What do you guys think about that? He's always everywhere, right? He's like fun, right? Like, I want to be here too. You got the other 9 organs. Well, it's okay. I want to be here too. So anyways, but yeah. So so his innervation goes from your proximal third of your esophagus down to transverse colon. So vagus nerve, it's got a nice little structure here detailing what it innervates in this particular region. So sacral nerves, the ones that are within your cauda equina, they're the ones that innervate from the distal third of your descending colon down towards your anal sphincter. Okay, so no difference with the parasympathetic division innervation there with those two. Didn't I mention this yesterday? Right? Yeah. So, splenic ruptures in emergency, so they're protected by ribs 9 through 11, 911, okay? It's in red, know where it's located. It filters your blood, so obviously if it's getting inflamed and ruptured, the only treatment is a splenectomy. They want to remove it, and then other organs start filtering blood for you, okay? So. And yeah, so your spleen is kind of like posterolaterally located. So, remember that left hypochondriac region? So that's where it would be more specifically located. Remember that from the first part of this lecture? So yeah, so know where that's located. I think we have 2 models of like that in the lab downstairs. So you guys watch. So this is the spleen again. north. So you can see it's kind of like tucked more like on your midclavicular line, so to speak. So um, a lot of car accident victims injure that area as a result. So here it is. So this is called splenomegaly. Okay, splenomegaly is when it's inflamed and it's enlarged. Hepatomegaly is what organ? The liver. Okay, good. Where's the spleen located?
9
Not on fingers. Yes, posterior laterally. Awesome. So we have our pancreas. Okay, so pancreas has lots of portions. It's located here in the epigastric region. So when someone, let's say someone like goes on alcoholic binge and drinks a lot, they can get into acute pancreatitis, which can also mimic signs of a heart attack. Yes, anyone complaining of gastric pain, I need you guys to order cardiac enzymes or EKG, consult cardiology. Rule that out as well, okay? Because that's also referred pain. Do y'all remember where the heart sits? Right on that diaphragm, which is close by. The pancreas is right there. So, but yeah. So I want you guys to be familiar with all the different structures here as part of the head, neck, tail. Don't get those confused. Know which ones are where. So that way we have an excellent idea where things are located. So pancreatic duct is in this portion. Your bile duct's coming from your gallbladder region. Common bile duct is down the center there. So when someone's gallbladder is removed, it's just a constant flow of bile down that common bile duct until it regulates in a few months. But think of it as your storage, and when that goes away, there's really nothing else. It's just kind of going on there. But I would get familiar with these structures here. Primarily where the main pancreatic duct is, the bile duct adjacent, like posterior to the pancreas there, and we'll go from there. So it's a big deal. When you get pancreatic cancer, what's the primary cause of pancreatic cancer? Do you know? Smoking, cigarette smoking. Okay. Same with cystic bladder cancer, smoking. Okay. Was it Steve Jobs, Patrick Swayze? Unfortunately, it happens very quickly once it's diagnosed. It's one of the quicker ones that unfortunately causes people to expire quickly. So, but yeah, it's an important organ. Does a lot of things for us. It's found retroperitoneal. Notice it's just the head and body and the tail. But I'm not gonna quiz you guys, okay? Just know that it's retroperitoneal, okay? I know that certain parts of it are like in retroperitoneal, peritoneal. I'm not gonna do that to you guys for that one, okay? Know what it connects to, and the adjacent structure is your duodenum, okay? All right, so sphincter of Oddi. You need to know where that's located. So when we have, there's a lot of like traffic going on in there. So sphincter Oddi is going to regulate. He's like a traffic light, basically. Okay, he's going to contract and open up and see who gets into the proper street or into the nightclub in Miami. He's like, no, you're not cool enough. You gotta wait outside. Okay, stuff like that. Like he's like the little guardian. Okay. Um, anybody from Miami? So, okay. So when I was in Miami, I grew up there. I was partying like a dumbass. I wasn't wasting money, but there was little passwords you told people, right? Password, and you got in. Yeah. Well, you all remember that or not? But anyways, yeah, you had to have the right sort of attire on to get in the club. You stood there for hours. All right. Now I look back, I'm like, that's so dumb. Why did I do that? I was just trying to fit in. I didn't know myself back then. But anyways, but I think of the sphincter Oddi as the guy trying to let certain people in and out. Okay, what's that? Yeah, the bouncer. Yeah, but the bouncer's like wearing a black sport coat and he's looking all mean, but he's a softie. He's a little teddy bear. Anyway, but yeah, so he's going to basically, decide who gets into the club or not. Okay, does that help you understand it? Yeah. Okay, all right, that was fun. All right, so the pancreas releases your insulin, glucagon. Y'all are learning that sooner or later in physiology class, okay? So you don't have to know the process of it, just know that what it secretes is insulin and glucagon, the main ones there. Um, and also some digestive enzymes, and that's what goes awry with pancreatitis. Your digestive enzymes just stop working. So here's some models of it. We don't have much GI models. If you notice, the third bookcase is rather bare. So I would rely on like the Netter's books and stuff like that, and Anatomage and your complete anatomy, okay? And here's what it looks like again. All right, let's take a 7-minute break, and we shall return. And we're on. So the liver, the hepatic organ found in your right upper quadrant, okay? Y'all have learned Murphy's sign and all that stuff there? Okay, all right, good. Liver, span, all that good stuff. Yeah. So liver can become diseased. I can get all sorts of things. Can get ascites, can get a condition called NASH, non-alcoholic steatohepatitis. I will share something with you guys. My father had a liver transplant back in 2006, 2007. He's still around. He was a Vietnam War veteran, and it was found at the time that he started having symptoms of hepatitis and inflammation and all that stuff. A slew of Vietnam veterans across the country were getting the same symptoms. So it was an agent called Agent Orange. Have you heard of it before? It's to kill all the green foliage. So they didn't care where he sprayed it on. He sprayed it on the troops, and whatever, 30, 40 years later, they started having liver issues. So my father was weighing like 90 pounds. He was cachectic. He had a protuberant belly, and he's a certified BA. Trust me. He's a Vietnam War veteran. He's an FBI guy. He did top secret stuff I can't talk about. I said too much. If I disappear, you know why. But yeah, but to see him like go from this like, you know, badass to like this, it really like crushed me. But he survived and he's still around right now. But yeah, he ended up getting a transplant finally. So it was like a car accident victim in Jacksonville. That's all we know. And they literally like flew the liver in a cooler, I guess, down to Miami and Jackson Memorial Hospital. He had a pager on him. They give you a pager just to be on alert. When the pager goes off, you have a go bag. Is that what they call it? You have your little pack and you just go to the hospital and they meet you there. So, but yeah, it's an organ that is vital for your survival, and if it goes south quick, things can happen. So yeah, but there are options now. You just get put on this waiting list, and some people survive, some don't. Fortunately, he's still around. He's still kicking butt, and I'm still scared of the guy. So he raised me with an iron fist. So I was like, all right, I have a little bit of him, not too much. I just don't take things as serious anymore. Just like whatever. All right, so sorry about that. I didn't mean to go on a tangent there. But falciform ligament basically divides these two lobes together, um, and basically that's the function of what that ligament does. Okay, and you'll have certain structures there. Look at what is this little guy right here? Yeah, that's your gallbladder. He's over here too, poking his head out. So hey guys, he's like on the outside looking in. So the sphincter odious left in the club, so he's like looking through the fence. Sorry, I'll stop. But yeah, know the adjacent structures, know what specific regions are where, um, and and that should help you guys. There's also other ligaments, but those are, I'm not gonna really worry about that. So your common bile duct's important, your portal vein is important, your inferior vena cava is important, okay? So know that very well. That's where it's located. So what does the liver do? It does all of these things. He's very busy. He's a very busy guy like y'all, okay? While we're studying, he's doing all this stuff while you guys are studying, okay? So know which one is the right side, which is the left side. If I were to put a liver in front of you, know which is right or left, okay? Y'all are getting better at that, okay? Awesome, okay. All right, so they have different lobes. If I were to ask you which one's the largest, you're going to say right side, okay? Kind of like the lungs. They got 3 lobes, right? And it's heavier and all this other stuff. So know these differences. They have little tiny smaller sections like when I have on your workbooks adjacent structures, this is what I mean. Like literally know where it's located. What's between the gallbladder and the ligamentous teres, which is basically going to give it structural support and keep it where it needs to be. So study this diagram well and know which particular lobes and ligaments are adjacent to each other, okay? This looks like a fun maze. Okay. Don't mind me. I did it! Okay, sorry. Alright, so so if you're looking under a microscope, this is what a hepatocyte would look like, a little part of the lobule. So yeah, it's basically you have your portal vein, central vein, hepatic vein, and this is just basically where everything gets drained into. So if you have portal hypertension, meaning there's lots of resistance to flow in the portal vein, it's going to back up into the liver and lead to ascites, lead to hepatomegaly, lead to asterixis, which is basically hydrochloric acid in your blood and gets into your blood-brain barrier, makes you hallucinate and do abnormal, altered mental status activities. Okay, I know that because that's happened to my dad. And he was frantically looking for scissors in the middle of the night for some reason. It was just and I had to call the paramedics, and his HCl was through the roof in his blood. So yeah, but. I tell these things so you can relate to this thing. It's a safe space. I feel like it's a safe space here. I don't care. I'll tell you guys anything. You all, no judgment here, okay? All right. So some more liver stuff. It's arcuate network of veins. So what is this big structure back here called? What's it called? Thank you. All right. What's this guy called? What's this guy called? What's this vein right here? This little tiny one that you can't see very well? What's that one called? Joking. Don't worry about it. But yeah, so the portal veins basically drain stuff from your intestines into your liver for processing and regenerating stuff and carbon skeletons and adipose tissue. So all this good stuff happens in the liver. But yeah, it's basically a big deal there, okay? So bile secretion, so oh my goodness. That looks like something you'll see in Dr. Kaplan's class, right? Yeah. How'd that get in there? Look, it's a club. You guys will never forget sphincter release. All right. All right. So just know, like, kind of like we went through with like the breathing, the nose to everything, and the alimentary canal, mouth to anus. Kind of like just know what structures the bile goes through, but don't worry about that last slide. That was archaic and maddening. Wouldn't that be upsetting if I said know it? What I was told when I was here. You have a book, right? Yeah, I do. Read it. I'm like, okay. I did read it. don't think he did. So. This is a shiny liver right here. This is a brand new one, right out of the shop. This is like the undersurface of it. So see how it's got around the diaphragm, the lungs have little like sections where stuff like fits in like a jigsaw puzzle. Same thing here with the liver, okay, on the undersurface here. So there's your gallbladder, hepatic artery. So it's just giving you a different viewpoint of it. So it's just looking straight on the liver where it's located. The liver. Last year we had a thing with the liver. I would say the liver, and everyone started laughing. I don't know, just I know why. Because so I'm not gonna do it this year, but last year I preceded this lecture with a YouTube video of liver shots in boxing matches. Because when people get hit, it'd be a delayed reaction before they hit the ground, and that's because the liver will like go into a delayed spastic state. And one of the announcers was like, "He got hit in the liver," so that was kind of like the thing the rest of the semester. But I don't know. I just thought I'd be more focused this year. Oh, it's just. Do you guys want to see it?
Yes.
Okay, next time. Okay, fine. I'll find it today. It's like I don't know if y'all. I was a fighter before. Some of you have already seen my office. I got me in like a cage and beating people's faces in. But when you get hit in the liver, it's not really pleasant. You get hit and you're just like yeah, and you just drop. It's like oh, it hurts really bad. You get into this huge spastic state right here. So yeah, liver's just got so much going on that they have delayed reaction. So that's what I wanted to show in the boxing videos, how awful it is. So um, I don't know if we'll have time to do it. So I don't want to take time away. How many want to watch that or not? Okay. All right, I'll see what I can do. Okay. All right. So we got your gallbladder. So this one, when it gets angry and inflamed or filled with gallstones, like to the brim where it blocks the bile from leaving, we need to do. There's other things that they used to do. There's called lithotripsy. You all heard that term before?
Yeah.
They kind of do like shockwave therapy to kind of break up the stones to let it out. That's kind of not used anymore. They'll give you antibiotics to see if it will calm down, but it's a horrible pain. I mean, people like are like keeled over with it when there's a cholecystitis attack, and they get put on antibiotics. It gets a little better, and then they get scheduled for surgery. I mean, the best treatment is to get a cholecystectomy, get rid of it. What they do is they go in through the umbilicus. They go in through this, make an incision. They use this little guide wire to kind of cauterize the ligaments off of it, and they cut it and then loop it right through. It's like a 10-minute surgery. So that's outpatient nowadays. So you already knew that? You did? That's how it's done. That's cool. But yeah, so it's basically its job is to store bile, but when it's gone, it's got nowhere to store it, so it just literally runs down the sides of the common bile duct, okay, and eventually it'll level out. But persons, nowadays you can eat whatever you want, like the general surgeons that I know, they just have them, they can eat whatever they want, there's no restriction, but uh, personally, I would probably not have them eat fatty food for a little while because it's going to create a lot of issues with peristalsis and all that stuff. But yeah, know where these particular parts of it, your fundus, your body, your neck, and look, we're using anatomical directional terminology here to find out where it is. Okay, between the right and quadrate lobes, and it's like this. Looks like an orthotic in your shoe. Look at that. How do you feel orthotics? I wear orthotics. Yeah, they're custom made, just for me. All right. All right. So you learn about what happens with CCK and when someone eats fatty food in physiology class, but just know that it releases bile when there's fatty food around. Okay. It's kind of like when my pups here sense that I'm going south quick, they start to alert me, and they put all their body weight on my legs. So So when it senses that there's fatty food around, it starts releasing bile, okay? That's your physiology class for today. It's mine's much more fun, right? What's that? All right, so the gallbladder is in green right here. So the biliary system, so this is what consists of it. So when bile is released from the gallbladder, it goes through all of these structures until it is basically reintroduced back into your hepatopancreatic duct and recycled and reused and all that good stuff. So know where it's going. Here's another model here. I'm not going to have you know the intricacies of bile physiology, like bilirubin and all that. Indirect, direct, that's for your other class downstairs, okay? All right, so there's no where these are located. Cystic duct is in yellow. And then here's what we've discussed, okay? All right, so let's take a 5, 6 minute, 8 minutes, 8-minute break.
So if you put the bile, like